quite live yet. Welcome back to another session of the COVID-19, the Digital Orthopedic Response, a virtual summit brought to you by the Digital Orthopedics Conference, the Department of Orthopedic Surgery at the University of California, San Francisco, in partnership with the American Academy of Orthopedic Surgery. The last session was very moving. Thank you, Luigi, for sharing all that information with us. We're now going to move to a somewhat related but different topic with Dr. Rutherford, Dr. George Rutherford, who is the Salvatore Pablo Lucia Professor of Epidemiology, Preventive Medicine, Pediatrics, and History, head of the Division of Infectious Diseases and Global Epidemiology in the Department of Epidemiology and Biostatistics at the University of California, San Francisco. So it should be clear at this point why he's our eminent guest, speaking to us today about the propagation of this disease in the United States. So, Dr. Rutherford, thank you and welcome to the show.
Thanks very much. It's a pleasure to talk with all of you. And I wanted to review the epidemiology and some of the public health issues that are surrounding the current COVID-19 pandemic. So just to start with, what are we talking about? Not trying to get too far ahead of your next speaker, but COVID-19 is a pandemic disease caused by infection with a coronavirus called SARS-CoV-2, which is a new beta coronavirus that emerged in central China in December 2019. The other beta coronaviruses are SARS and the Middle East Respiratory Syndrome. The primary target of the virus is the epithelial cells of both the upper and lower respiratory systems. And the clinical disease is characterized by cough, fever, dyspnea progressing to hypoxemia, respiratory distress, and ARDS. The mortality rates vary, but they're sort of roughly about 4% of recognized cases. There's a large amount of asymptomatic and mildly symptomatic infection that does not reach medical attention, probably on the order of half to more. And these are estimates from China, but 60 to 80%. The infection itself is caused by droplet spread of virus-laden respiratory secretions. Its incubation period is 5 days, and people are infectious, shedding virus from 1 to 2 days before symptom onset. And then, as we've heard, and we'll hear much more detail later, disease outcomes are much worse in elderly and those who have underlying medical conditions. And up here in the corner is a cartoon of the virus and the purple mauve lilac thing, so-called S protein. That's the protein that anchors to the receptor sites, which are an angiotensin converting enzyme to receptors. Here is a slide from the World Health Organization as of last night. This gives you an idea of where this has gone in the world. These are by WHO region, so they're not totally clear. I'll explain. This is China. And this big jump here on the single day is because of a change in case definition, where they moved from a laboratory case definition where you had to have positive PCR to one that included chest CT scans. They just didn't have enough test kits at that time, so they changed to move to a kind of a clinical pneumonia case definition, or radiologic. If you follow the orange out, there's another bump back here in the back. That's an epidemic in South Korea, which is highly instructional for the United States and is one that we look at with very closely because they've managed to do a much better job of controlling the virus without having to go to shelter in place. This salmon-colored, pinky-colored, this is Europe, and Europe is the hotbed, the ground zero for this infection now, with the greatest number of cases when you add up across all the European countries, and far and away the highest mortality rates, on the order of 10% of recognized cases. And then finally, the purple here is the Middle East, which is largely centered in Iran, that has more than 40,000 cases and has seeded a number of states around the Persian Gulf and into Saudi Arabia. And then finally here, the yellow is the Americas. This is almost all U.S. and it is this is predominantly in the United States and predominantly in the tri-state New York City area. This little cap at the top is kind of interesting. This kind of gray cap up here on top of some of these things. These are cruise ships, and cruise ships are a very interesting topic and one that we'll have to come back to another day. But my advice is don't take cruises this summer. The current epidemiology as of last night was that there had been 932,000 cases reported from 180 countries and territories. You can see there are very few, like Yemen here and South Sudan, that don't have cases. About 5% of the reported cases have died to date. In the beginning, when I started to do this, there were 97% of cases were coming from China. It's now down to less than 10%. All the cases in China are centered around, or most of the cases are centered around one province, Hubei province, which is about here, kind of just maybe 300-400 miles inland from Shanghai, in a city called Wuhan, which is the capital city, a big city, 11 million people. And that was where the great preponderance of cases occurred in China. That was the first city to go under lockdown and is still in a shelter-in-place kind of intervention. And they're gradually releasing that as fewer and fewer cases are occurring. They've had one case. They had one case yesterday and one the week before. So it's down from a high of 19,000 on one day. The epicenter has now really moved to the United States with 213,000 cases, which represents a quarter of the cases in the world. And Europe, which has 56% of the cases in the world and 74% of the deaths, with particularly hard-hit countries being Italy, Spain, Germany, and then to a lesser extent, France. And as I mentioned before, Iran is a heavily affected country. And then in the past, South Korea has been. So the outbreaks move centripetally from China out to neighboring Asian and Eastern Pacific countries, to Iran and the Middle East, and then to Europe and North America. So just talking about the United States, as I said, there are 213,000 cases and 4,757 deaths as of last night. Almost all of them are from an unknown source and are presumed to be caused by local transmission. There were some early clusters that got some press, one in a nursing home in Kirkland, Washington, another around a synagogue in Westchester County, New York, and a third from a business conference in Boston. Early on, the epicenter in the United States was in Washington State, up in King County, where Seattle is, and the surrounding counties. But that epicenter has quite clearly moved from Washington State to New York City and northern New Jersey, which in New York it now accounts for 40% of all U.S. cases and 1,900 deaths. There's been a really dramatic surge since March the 16th, as you can see in this histogram over here to the right. And part of that's because testing increased dramatically. Part of it is that you're really seeing an exponential rise in the number of people who are hospitalized and who are sick enough, which has created a huge strain on their healthcare system. And as you know, probably the East Coast hospital ship came from Newport News and arrived in New York Harbor the last few days. And the military is setting up field hospitals to take the patient overflow, not so much to take COVID patients, but to take patients with other diseases who are being moved out of hospitals. The disease is going to the Midwest. There are new foci of transmission in New Orleans, Detroit, and Chicago, where there's quite a bit of clinical disease. The New Orleans outbreak in particular followed suspicious that led to a ton of amplification. Okay, we can skip that. This is the current map of the United States. You can see this very large cluster in and around New York City that includes New Jersey, Connecticut, upstate New York, and to a certain extent into Pennsylvania. Other large foci are in Detroit, Chicago, New Orleans, increasingly in Miami, Washington State, Southern California, and then the Bay Area. These are data from CDC from a first case series looking at hospitalizations through the middle of March. This is these on the y-axis, these are actual numbers. On the x-axis are age groups. And you can see that while clearly the proportion of deaths or the proportion of ICU admissions goes up over time, the older you are, right? There are ICU admissions that are occurring in people under 45, and there are hospitalizations, at least at this point in time, in people under 20. So it's not that it doesn't happen in younger people. It's just less likely to happen. And because this is being kicked around the White House right now, and the White House task force, these are the University of Washington's models for the United States, where you have here in the purple dashed line the projected bed needs, inpatient bed needs. In the green dashed lines, the predicted ICU bed needs, and then the blue dashed line, the predicted numbers of ventilators needed. This is peaking. It's projected to peak on April 15th. And here, if you do the math between what's available, what's needed, and then you come up with the shortages, which are profound. To be 13,000 ICU beds short is a real problem. And this is all mal-distributed. It's really in the Northeast now and in a few large cities like New Orleans and Detroit and Chicago, where the demand is really high. Other places have more capacity, but even if you were to average it all out, there would still be a shortage of beds. People talk about flattening the peak all the time, and this is what it looks like, at least if you believe cartoons. This is this acute rise here that we see in brown. That's what happens. That's what's happening in New York. You're in an exponential phase, right? And eventually will turn over and start to fall down. Meanwhile, you'll have this huge problem with hospital capacity if this dashed red line is indeed what your hospital capacity is. So what we try and do is decrease the number of cases, spread out the chains of transmission longer and longer, and have the so-called flattening of the curve. Now, everybody asks, is it the same area under the curve? And the answer is no. There are fewer cases in the blue curve as we move forward in time. But the point is that you've decreased the peak, so you've decreased the burden from the daily hospital admissions. So how can we prevent this at the population level? Well, the first thing we do, and the first thing we did here, was containment, which is about information and education, promoting respiratory hygiene and hand washing. Then we advise people to start taking individual measures to increase social distancing. Obviously, we always have eye contact. Then we do contact management, which means isolation of people who are infected and quarantine of people who have been exposed. And then finally, hospital and facility infection control. When that fails, as it did here a while ago, we move to mitigation, which include community-wide measures to increase social distancing. Things like telecommuting, banning large gatherings, business, school, and transit closures. We haven't closed transit here yet. Widespread community quarantine or shelter in place, which is what we're doing. And then border closures. The United States is essentially shut down to foreign travel at the present. Now, incredibly important are the lessons that we can learn from the 1918-1919 influenza, which devastated the world and the country, coming right on the heels of World War II. There were millions of cases and hundreds of thousands of excess deaths in the United States because of this. So what did we do in 1918? Well, different cities did different things, which allows for these great experiments of nature, and we can see what the consequence of those were. So here's one example. So the blue line is Philadelphia, and the red line is St. Louis. And the dates aren't important. It's really kind of a function of when the first cases were occurring. That was what was triggering this. So in Philadelphia, where the first cases occurred earlier, they had a very rapid rise. They moved to the kinds of restrictions sort of here between 150 and 200 deaths per 100,000 population. And then it fell. St. Louis did a much better job. They got the disease later. They were prepared for it. They closed everything. They did shelter in place. And so they had this very flat curve. Then they let their foot off the brake, and there was this rebound. Okay. So this is something to be cognizant of right now. This is where we are. We're trying to do this part, trying to flatten the curve, but there will be a bounce back from it. And hopefully we'll be able to control it with more traditional methods. So the question is will all this shelter in place work? So here are two Italian provinces in the Lombardy region, which is by Milano. It's northern Italy. One of these, Lodi, began a shelter-in-place program on February 26th. Lodi, by the way, was ground zero for the Italian epidemic, with one patient presenting to an emergency department in Costogno and ending up with infecting like 35 people. So this is the ground zero. They went to shelter in place on February 26th. A province and a half over in Bergamo, they went to shelter in place on the 9th of March. And you can see that these huge differences that have been interpreted to be a consequence of early versus later sheltering in place. In California, where we moved statewide to shelter in place on March 20th, on the Bay Area, where we moved to 6-county Bay Area, where we moved on March 16th. This is what IHME at the University of Washington is projecting, with peak ICU use and bed days peaking later in April on the 24th, but having no shortage of regular beds and maybe a 30% shortage, something like that, no, more than that, 15% shortage of ICU beds going forward. This is not 300 ICU beds is not that hard to find. For instance, we have 3 children's hospitals in the Bay Area. We can consolidate their pediatric ICUs and open up beds for adult patients. You can repurpose operating rooms to use anesthesia machines. There's some experience in New York with splitting ventilators between 2 patients being on the same ventilator, all those kinds of things. What we think is happening in the Bay Area is going to peak much sooner than this, and it's going to peak below maximal usage. So if we can get our patients through and out, we can be in reserve for patients from the rest of the state should there be spillover. So that's where I'll stop, and happy to give it back to you, and Stefano, and we can go from there.
Outstanding. I'm coming back with you just now. That was a fantastic rundown. A lot of questions have come up, and I will also ask you a couple of questions real quick. So I was thinking about this pandemic is evolving rapidly. You've made a very clear show of telling us what the impact has been of sheltering in place early and doing this proactively. Those are some fantastic examples. Let's talk a little bit about the little peak you saw. What was it, St. Louis, when they let the foot off the brake? Mm-hmm. Talk a little bit more what that looks like. How would that happen in an area like the Bay Area, for example, that has been successful early and might not take this as seriously as you might want us to?
Right. So in St. Louis, that probably represented indigenous transmission within the population. For people who, there are lots of reasons that you don't completely stop transmission from shelter in place. First of all, you have people who entered shelter in place who are incubating the disease. They transmit it to one person in a household. That person transmits it to one more person, and so on. So you can have little chains within households, even if shelter in place is perfect. The second thing is that we don't really shelter people in place without any restrictions. People get out, they can walk around, they go to the grocery store, they go to the post office, they go to wherever they go. And so there is some chance for exposure outside the home. The third thing is that a lot of people are healthcare workers, and at least early on in these epidemics, the experience has been is that healthcare workers can get infected early. The proportion of the cases in Italy, like almost 10% of the cases in Italy are among healthcare workers, is that early on, before all the infection control stuff really gets clicked in, and they just use the same teams to intubate everybody, for instance, who are really experienced. There is transmission to healthcare workers, and they can bring it back after the shelter in place, or they're going to coming. And then the fourth thing is that there are importations, people coming in from the outside who are infected, and that's a problem. So we're looking at our concern is that as we look down the road to us being out of shelter in the place and other big cities in the country who have not done it, that they'll be able to reseed the Bay Area from coming outside. And that's one of the reasons you hear the White House task force pressing for essentially all governors to take up shelter in place. Just legally, by the way, that's a state or local responsibility. The federal government couldn't do it if they wanted to, if they don't have the legal authority.
That's an excellent point you make. I want to go back to one point. It came up in the last session, Dr. Zagra, the session before Dr. Wang, about China. They felt that the transmission amongst healthcare personnel was low, assuming they were appropriately shielded and guarded, and that the bulk of the transmission happened amongst people who are exposed to the aerosols of high sort of bronchoscopies, tracheostomies. Is it fair to say that the very high problem they had in the medical community in Italy was largely because at the beginning they just weren't appropriately sheltered, but that if you were to look at currently, assuming people are doing the appropriate thing, that the risk is more mitigated? It's still a very high risk.
No, I mean, I think that's absolutely right. Actually, the experience from Wuhan was that there was quite a bit of healthcare worker transmission very early on, before people realized what was going on. And I would suspect that was the case in Italy as well. So China sent in 46,000 extra healthcare workers into Wuhan to try and control the epidemic. The infection rates among those people were very low. And I would suspect we're talking about the same thing in Italy now, that the healthcare workers that were infected got infected fairly early on. And, healthcare workers don't have to get infected at hospitals. They can get infected in communities. We have infected healthcare workers at UCSF. We think every single one of them was infected in the community because they didn't come into contact with patients in the hospital. So healthcare workers are also part of community chains of transmission.
Yeah, plus they're moving. They actually have access. They're allowed to go to the hospital back and forth.
Yeah.
Okay, let's get to some of these questions. We have heard a lot about the use of masks. How about the reuse of masks and gloves in the community? This from Dr. Oberlander here in the Bay Area.
Thank you. So I think what we will see is that as we move away from shelter in place, or even before we move away from shelter in place, that there will be new guidelines, recommendations, orders, I'm not quite sure what, to wear masks when you go outside. And the idea with masking when you go outside is not that it's going to prevent you from nasty cough. It's not going to prevent you from getting infected, but if you're asymptomatically or mildly symptomatically infected, it's going to prevent you from spreading it. So the onus is on you. There's an assumption that you are the one who's infected, and the masks are meant to cut down on that. So yeah, you can reuse them. Gloves, sure, you can reuse gloves as long as they're clean. I mean, the problem with gloves is that you touch everything with them, and then you touch your face, and you think you're magically protected. Not you, Dr. Oberlander, but people think they're magically protected by having gloves. That's only as long as you change the gloves, take them off, wash them, and you can rinse them in some bleach solution. That would all be fine, but I don't know how the bleach affects the half-life of latex. I can't imagine that it's that good for it.
Good.
But understand the business with masks is about preventing you from transmitting.
Right. When can we safely take a previously COVID positive patient, now theoretically healed or healing, back to surgery? Is 3 weeks sufficient by itself? Is time plus a negative test And the concern here is relative to the operating room staff's exposure, obviously.
Understood.
This is from Dr. Barber in New York.
Sure. So I would imagine the anesthesiologist will be wearing lots of protective garb for quite a while to come. I would say that if they've had a negative test, they've had a negative test. And especially if it's an NP swab, a nasopharyngeal swab, where the yield is the highest.
These questions come up a lot. Can masks or gloves be reused, and are makeshift masks or scarves useful when going shopping for food? Say wearing literally a scarf over your face. I presume somebody makes a mask out of cloth. Are those sufficient to create a barrier? Oh, did we lose George? Oh, George, he'd have to refresh his system. One second, we'll reach out to Dr. Rutherford. He's refreshing. He'll be right back. Yeah, there's a lot of questions here about the question about masks, and we'll get to that. Right. There you are. You're back. Perfect. Yeah. So this question is around masks. They're makeshift masks. The company you make. Yeah.
Yeah. They work okay. They're not as good, but they're okay. And the point is, again, we're not trying to prevent you from getting infected. We're trying to prevent you from infecting someone else. So there's a presumption that everybody has asymptomatic infection as they go outside.
So with that, a little cough there.
Did you see that was a non-demonstration of respiratory hygiene, by the way?
Exactly
I saw there was one right there.
Oh, terrible. I didn't. So the point of the mask
is I immediately touched my nose, so go ahead.
There you go. Yeah, we're all. So the question is that the mask isn't really intended to protect me as I go to the grocery store.
Yeah,
because it's really so that I don't infect others.
It's to protect everybody else around you. Yeah, it's to protect everybody else around you. So if you want to look like a bank robber from the Old West, probably works pretty well. Yeah.
Next question, Zachary Child asks, what is a known risk of aerosolization of this virus in electrocautery smoke, the bovie smoke?
Well, I know what bovies are, but I have no idea. I can't imagine that the electrical current doesn't kill it, but I don't know. I mean, if it's an aerosol generating procedure, and you're working or going through respiratory epithelium, I think you have to talk to your infection control chief about what their interpretation would be.
Right. So we're trying to keep in mind that the virus lives in the lungs primarily. If you're cutting through a muscle with a bovine that's generating smoke, that's not likely to generate. Plus with HIV, if I remember correctly, the viruses, they could find DNA in the smoke, but they couldn't find living viruses. Okay, on to the next question. How do you comment on the possible second wave of epidemic in China? This from Liang Go.
There is some new transmission in China. According to the data I've been seeing, it's mostly in Taiwan and Hong Kong, which get counted as part of China in the UN statistics. My assumption is that it's been from people returning home from overseas and bringing COVID-19 with them. I know there's a lot of suspicion about Chinese numbers. I know that the World Health Organization looks over their shoulders pretty closely. The one set of numbers I don't trust are the Russian ones. They seem way low. And the Iranian ones, I think, are reasonably accurate, but you really can't look at them day to day because they go on and offline with their accounts.
Excuse me. Bad hygiene. Oh, God, terrible. I'm going to go get myself. I've been tested. It's negative, but a question mark, is it true? Anyway, we'll see. Professionals treating COVID positive patients go home. What should they do? Sleep in separate and independent beds if available. Wear masks at home just in case. Avoid contact with their loved ones. What are your thoughts?
That's a good question. I mean, my wife goes to the hospital every day. I threatened to make her take all her clothes off in the entry hall, but
wait.
that hasn't happened yet. I know people go and they'll change clothes, they'll take a shower, and then come back into contact. It seems, it seems not unreasonable, but I don't know. There's really no data on it at all. There are no cases that we know of, but not every single case gets investigated in great detail. So yeah, maybe it could happen. I mean, I don't think that so much as fomite transmission on your clothes, which presumably you have you've had some protection on if you're taking care of patients. It's more that you've become occultly infected and may have asymptomatic or even mildly symptomatic disease. If you're symptomatic, you should clearly isolate yourself away from them. But short of that, it's a tough question. It's in between call.
When can a previously positive surgeon or anesthetist return to work?
I'd say as soon as they're not infected, as soon as they're non-infectious is determined by a PCR test of their nasopharynx. And
so a negative test for the virus, not for the immunoglobulins. So that's another question.
Those antibody tests aren't available yet.
Okay. When they do become available, the ELISA serologic assays, how successful do you think this should be rolled out across the board, or what do you think?
I think it adds stuff. Our current reading of the immunology, kind of the timing of the immunologic reaction, is that the tests don't become positive until day 10 or 12 post-infection. So they're not going to help us with acute diagnostics. They're going to be more useful for serological surveys for epidemiologic purposes, and also for potentially cohorting people together. So, for instance, if you have antibody positive nursing staff, you might assign them to the really frail elderly, like in a nursing home, or have them take care of the COVID patients. We had some experience doing that with Ebola in West Africa, and it seemed to work out pretty well. I mean, if you've been infected and it turns out you have antibody, you are presumably immune, and you're presumably not shedding virus anymore, and you can go back to resuming life.
So let's talk a little bit about that. There's been a lot of question whether or not this coronavirus does confer immunity if you've had it, and if it confers immunity, how long it lasts. Do we have any? I know there's still a question out there in the scientific community, but do you have any thoughts to share with that?
Sure. So this is just gross speculation. Well, I can tell you. So I'm a pediatrician by training. I can tell you, alpha coronaviruses, the ones that cause colds, do not confer immunity of any great duration. However, the MERS and SARS, the other two beta coronaviruses, seem to have create immunity in people that lasts for a while. I think
being,
we don't know. I mean, SARS was over within a year. It came and went, but there were no reinfections reported to my knowledge. So I think that the smart money says that this confers long-term immunity, meaning over years. Is it lifelong immunity? It might be. It's hard to get lifelong immunity when a virus doesn't circulate in the blood, but you can't imagine if it gets into deep into the respiratory system. I think that maybe the immune response is going to be a little bit more robust than if you just have an upper respiratory infection from it. But again, this is just rank speculation. But we better hope that it confers long-term immunity, or else there's no point in having vaccines.
Right. A lot of questions about testing. What the best, most successful way to test to see if someone's positive? We've got nasopharyngeal swabs. Mm-hmm. We've also got CT scans. I assume the CT scan is more of a delayed response because,
sure.
What are your thoughts about what's the best way for us to know if a patient is positive? There's a lot of surgeons asking that question.
Sure.
Taking surgery.
Well, they're only going to have positive CT scans if they have pneumonia, right? So, I mean, if you want to sort of sort out who's currently infected, and who's not currently infected, it's nasopharyngeal swabs. You shed much more virus in your nasopharynx than in your oropharynx. And so you have to really, so that's if we used to do two swabs, both oropharynx and nasopharynx, but the yield was so much higher for nasopharynx that we moved to all nasopharyngeal swabs. Now, unless you're in otolaryngology, you may not remember how unpleasant nasopharyngeal swabs are, but they're people don't like them.
Yeah.
And one of my colleagues said they were going to do one on me, and I thought, this is going to come back as normal frontal lobe from pathology.
I did have one done because of my cough.
You got to go about here, right?
Yeah.
So you can imagine.
Don't want to get two more questions before we start heading down the path of closing out the session. Has been really great. There's a couple of points that keep coming up in the Q&A, but have also been made. Is there any truth to the issue of warm weather being protective? Warm, moist weather being protective?
Is that President Trump asking the question? Or?
No. That's actually Brian Lumen from
Dr. Lumen. So
the Bay Area. Actually, not Dr. Lumen, but Brian.
All right.
Lumen, yes.
Well, whomever.
Brian.
Okay, three things. First of all, influenza goes away in the summertime. It doesn't go away. It goes to the southern hemisphere and circulates in the southern hemisphere. I think, why does it do that? I would have answered the question. I answer the questions because kids are out of school. For influenza A, schools are huge incubators, particularly elementary schools. And when they go, oh, I'll go home in the summer, you get rid of that as an incubator, and so the transmission rates drop off. On the other hand, there are influenza A and B especially, outbreaks from time to time in the summertime in nursing homes, so it doesn't completely go away. Now, if you want to, so that's one line of thought. Yes, it happens, but it happens more likely because kids are out of school than anything else. Second thing is that COVID-B is circulating the southern hemisphere now with outbreaks in Brazil, South Africa, and Australia and Chile. So it can clearly happen in the southern hemisphere during their summertime, although the summertime's coming to an end, but it can happen. And then the third line of reasoning is, why would a disease go away in the summertime? Well, it's maybe because people are outside more, they're less crowded. The virus may get exposed to more to higher environmental temperatures, and most importantly, the virus gets exposed to ultraviolet radiation. Ultraviolet radiation, more than anything, just kills these guys deader than a doornail. So one country, and this is going to sound crazy, but one country I look at every day about what's going on there is Ecuador, because as the name implies, it's on the equator, and it also has really high mountains. So if any country in the earth, it's the closest to the sun and should have the highest UV profile. And so if there are no cases in Ecuador, good news. If there are lots of cases in Ecuador, don't get too enamored of the summer hypothesis. There's actually some experimental evidence in animals that says that influenza virus is more easily transmitted at low and drier temperatures. So, but that's a single study. We're not quite sure how to fold that into this logic.
I have to pick one question. There's at least 30 still sitting there. I think I'm going to ask this one. How do you comment on generalized masking in Asia versus no masking policy in Europe and US for flattening the curve, specifically as a method to flatten the curve? Should we all be wearing masks?
So we talked a little bit about masks beforehand. Masks aren't to prevent you from getting infected. I mean, the way we would use them, but with the presumption that anybody that we can't tell who's asymptomatically infected or mildly symptomatically infected, like you, walking around with that cough. And we should be masking ourselves to cut down on our risk of transmitting the virus to other people. Masks are worn are much more culturally acceptable in Asia. I know in the Los Angeles city school systems, as you get farther out towards the San Gabriel Valley, they've had to do a bunch of policies well before this about the students wearing masks for air pollution, for instance. They're just much more culturally accepted, and they're much more readily available. What we don't want is everybody to run out, as the Surgeon General said, and buy masks and strip the supplies away from hospitals. That's totally counterproductive, because all we're trying to do with masks is to prevent transmission out, not to prevent acquisition.
That's a very important point to end on. I want to thank you for participating in the Digital Orthopedics COVID-19 Orthopedic Response virtual seminar that we're hosting live, and your contribution was remarkable. And I really thank you for taking the time out. You're doing these almost 2-3 times a day, sharing the information that you're sharing, and we appreciate you doing that work for us. And for the record, I've been at home for a month with this cough, so I've not been shedding. So there, I'll be clear on that. And I was negative. But with that, I want to close out this broadcast. Invite anybody to tweet about let people know we're here and they enjoyed the summit. Our hashtag is #COVID-19 DOCSF, DOCSF. And with this, I'm going to turn the podium over to my co-host, Shauna, who is going to be in the next session, and she will call you in to hear from Dr. Brian Schwartz on clinical considerations for surgeons. He's an infectious disease physician. A lot of questions that were asked in this segment will be answered in that one as well. So once again, thank you so much, and I'm calling this to an end.
Thanks. So we good?
I think it's still broadcasting. It's just taking a second, just so you know.
Don't do anything embarrassing. Okay, got it.
No, not yet. I did end it. You know what I'm going to do while this thing is taking a minute? It's kind of stopped, but there were some questions we didn't quite get to. What are your thoughts on, there's people looking at re-sterilizing masks, or you're not supposed to use them again for 4 days. 1 second. Can you answer that question while I take care of one thing real quick?
I don't really know. I mean, if Brian's going to be on next, I'd ask him. There's CDC's put out. I know CDC's put out elaborate guidelines about sterilizing masks and reusing masks. My impression is that you should use them until they fall apart and then get a new one. But I don't know the specifics of the answer. Sorry.
Got it. I see that another question you can answer for us is, if I remember from memory, trying to remember what everybody was asking me. I can't remember, so I'll ask you a question. I had screen. Oh, there it goes. I think we may have crashed the system.
I'll check on the.
I think we're still live. I apologize to everybody for the delays. I think we're still live though. So there's a question about screening. This whole idea of screening is still confusing for people. If somebody comes into the hospital with a broken hip, we screen everybody, correct?
You mean UCSF? I don't know what UCSF's policy is.
No, but in general, what would you recommend?
I think it's helpful.
It's helpful. Yeah, that's what Chinese is doing. They're screening everyone.
Yeah. I mean, I think it's helpful, but I wouldn't be, certainly if they're elderly, I think it's worthwhile. I mean, they're going to be at risk coming into the hospital. And I think it's not, it's not the worst use of tests. Again, it depends on test availability. If you're in New York where there are lots of tests available, great. If you're here in San Francisco where there are not that many tests available, probably somewhat problematic.
And once you're in the hospital, how about the staff, the surgeons? They say in China that they test them regularly because they're assumed to be exposed. Do you suggest that that's also a possibility or an appropriate way to run that?
What I would tell you is that if we're in a long-term care facility I think all the staff need to be screened. Okay. Short of that, I mean, again, it depends on availability. I would think of lots higher risk groups that I would screen before I screened unexposed surgeons. For instance, I would screen, patients with suspected clinical disease. I would screen people who live in homeless shelters. I mean, there are lots of other pressures on the test. And if you have them, great, that's fine. But remember, surgeons operating on people are going to be wearing masks, and presumably they're going to hopefully be wearing gloves. I think that I think the chances of an infection from an infected surgeon to an uninfected patient are probably close to negligible, given the precautions just for sterile surgery.
We're trying to understand. I think just as an aside, I think that the network is either crashed or partially crashed. So we are still broadcasting on some streams, but not on others. And I actually can't stop it. So if there's nowhere else for you to go, I think we could have a conversation at some point. I think we actually I just finally went dead on my own line.